Okay, good evening, everybody. My name is Dean Carson. I'm one of the board members here at the Raymond A. Wood Foundation. It is my pleasure to introduce Dr. John Ragheb as our speaker for the April edition of our monthly learning series. Dr. Ragheb is Director of the Division of Pediatric Neurosurgery and Chief of the Department of Surgery at the Nicklaus Children's Hospital in Miami, Florida. He's also the President of the American Society of Pediatric Neurosurgeons. In 2019, Dr. Ragheb performed a focused ultrasound procedure on a young girl who had lived with a hypothalamic hamartoma from 6 months of age and had developed hypothalamic obesity. The destruction of the tumor through the high-intensity ultrasound procedure ultimately cured her HO symptoms. This novel method of tumor removal is now being studied in pediatric and young adult patients in a clinical trial that Dr. Ragheb is leading. We welcome Dr. Ragheb tonight and look forward to hearing more about this innovative treatment. Over to you, John.
Thank you, Dean, and thank you, Amy, and the rest of the board for the opportunity. Let me see if I can make my screen share work. Can you all see that?
Yep, looks good.
Great, thank you very much. Thank you again for the opportunity. Good evening, good afternoon, wherever you happen to be, good day. It's my privilege to be here with you this evening and to share our experience using focused ultrasound to treat benign tumors of the central nervous system in children. I'll start as usual with a disclosure. This study is a research study, and so technically speaking, what I'm going to speak to you about tonight is, because it is research, it is what the Food and Drug Administration in the United States calls an off-label use. This research is being done under an investigational device exemption. The tool we are using is FDA approved for the treatment of tremor in adults. I'll speak to you about that specifically, and the project is supported by a grant from the Focused Ultrasound Foundation. I have no financial relationship with the company that makes the device, and I receive no financial support from them directly. You may be asking who is Nicklaus Children's Hospital or Nicklaus Children's Health System. So I'll give you a brief introduction. We began as what was called Variety Children's Hospital in the 1950s. This hospital was built over the span of a decade at the edge of the Everglades on what was beyond the border of the city of Miami proper as a polio hospital. It was a place for the children to get fresh air and to be away from the rest of civilization. The hospital evolved after the Salk vaccine in the 1950s, slowed polio and its prevalence to become a children's hospital, and has morphed over the years into Miami Children's Hospital, where a new building was built in the 80s, and then finally into the existing building. And through a generous donation by the Nicklaus Family Foundation, the hospital was renamed in Jack Nicklaus's honor as the Nicklaus Children's Health System in 2016. We're happy to be in this building. It houses the neurology and neurosurgery patients, our intraoperative MRI suite, as well as our focused ultrasound unit. And I work with 5 very talented neurosurgeons. The 2 senior gentlemen on the left no longer practice clinically. At least they don't practice in the operating room, but they're involved in teaching and patient care. And then my 3 associates, Toba Niazi, Heather McRae, and Shelley Wang, round out our team in Miami. We're all full-time pediatric neurosurgeons. We are known in Miami for epilepsy surgery, among the many things we do. And I'm fortunate to be part of the program now since 1996. One of the things that Miami has been known for, and children have come to us from all over the world, has been to treat epilepsy. And that's really the segue of our research project into using focused ultrasound therapy for tumors in children. Our program started treating epilepsy with operations for children whose seizures could not be stopped with medicine in the 70s, and proved that you could put electrodes inside the head of a young child, that you could map the seizures, and that you could then remove those areas safely, and that the children would thrive once you stop their epilepsy. It's evolved from using plain old x-rays like this to using fancy 3-dimensional imaging that recreates the position of the blood vessels, and it's made my job much easier over the years, because technology has really enabled neurosurgery to evolve to create better results with less trauma And we'll talk about why that's so important when you treat benign lesions that are deep in the center of the brain. The juncture between our little children's hospital on the edge of what used to be the Everglades and this device that's approved to treat essential tremor in adults travels through Haifa, Israel, and the company Incytec, which makes the unit that we use. There's a family that's been here in Miami and very involved both socially and politically, the Ferrer family. They became involved in the company and they moved the headquarters for North America to Miami in 2016. They're benefactors of the hospital, and a relationship between our CEO and the Ferrer family resulted in our acquisition of one of these units at a very early stage before the device was even FDA approved. FDA approval for the device came in 2016, and that was specifically for the treatment of essential tremor in adults over the age of 21. Now recently, it's also been approved for what's called tremor dominant Parkinson's disease. This is a picture of our 3 Tesla magnet with the focused ultrasound table docked in place. This is the transducer system that delivers the ultrasound when the unit is inside the MR scanner. I'll talk more about the specifics here in just a second. There's been a rapidly expanding interest in focused ultrasound therapy. There are now, at last count, over 30 centers in the United States doing focused ultrasound treatment. The company Incytec has now become very large. What's even more exciting is that there are over 30 different centers across the world doing clinical research, studying the role of focused ultrasound treatment to treat central nervous system disorders. All of this work, though, is in adults with the exception of our center in Miami. Focused ultrasound treatment can affect change or be used as a therapeutic tool in 3 broad fundamental ways. And those include obviously creating a lesion by generating heat, by disrupting the barrier between the bloodstream and the brain, which is called the blood-brain barrier. It prevents large molecules from entering the brain, but it also prevents medications that might be of therapeutic benefit or being able to deliver other sorts of larger biological targets into the nervous system. And focused ultrasound is being used now to disrupt the blood-brain barrier to be able to deliver large molecules and therapeutics that don't otherwise cross the blood-brain barrier. And then the other promising modality is what's called neuromodulation. And I'll allude to that at the end of the talk. It's happy to answer questions about those 2 very exciting topics, but the focus today is going to be essentially on how is focused ultrasound energy used to create lesioning in the brain, and how do we use that to help children and their families with benign lesions that can't be reached otherwise safely. By way of review, I promised just some background on how focused ultrasound treatment works and how it's delivered. And this is a photograph of the ultrasound unit, which is mated to a table on the MRI machine. This unit contains 1,024 transducers, which create sound energy. And that unit is positioned in this dome. The dome is coupled to the patient's head with a rubber gasket that fits tightly around the skin, which is then filled with fluid. And sound waves then travel through the skin, skull, and membrane of the brain called the dura to reach a target that's very precise. And what this 3D cartoon shows is that energy is delivered very precisely within a few millimeters. This is a 100 micron scale, 1/10 of a millimeter scale, showing that there is normal tissue out here, and then area of damage which results in necrosis and death of cell tissue here. And there's a very discrete margin between the area of damage and the healthy tissue on the outside. What's important to know about this is, for those that are interested in the technical aspect of it, is that these are uses radio frequency to generate sound, and that can be electrically focused, which helps us fine tune that target and be able to adjust it in space, up, down, right, left, and front, back. Ultrasound systems have been used in medicine for a very long time, and many people have experience with them. The most common one perhaps is when a mom is expecting a baby and they'll use the ultrasound to be able to see the baby. or you're having an ultrasound of the abdomen to look for a kidney stone or to examine the bladder. Those ultrasound systems are called parabolic systems, and they have a curved source of sound energy, which is then used to look through and see an image based on the reflected sound. Body-focused ultrasound units are also very similar in principle. They focus the sound waves on a very small area and create heat energy. That's in contrast to the radio frequency ones, which use a focusing and radio frequency sound generation, and where the sound waves cross is where the heat energy reaches its maximum. That heat energy, when delivered to the brain, can damage brain tissue based on the height of the temperature rise, how high does the temperature get, and how long does it stay elevated. And a great deal of work has been used to study this in animal models to show that neurons, the basic working units of the nervous system, will stop working when the temperature reaches 42 degrees centigrade. And that as temperature rises above that level, proteins begin to fall apart. And then beyond that point, depending on how long that temperature is sustained for, that ultimately results in cell death. So there are computer models based on this extensive research that shows a combination of temperature and time will create an expected degree of damage to tissue in the nervous system. And we use those computer models to be able to adjust how much damage we create and where that damage goes. That's done through a highly technical process. And I'm happy to answer questions about that at the end for any who may be interested. But the computer system that drives the Insightec Exablate system creates a graphic interface that shows you all of those 1,024 transducers, where they'll pass through the skull and at what angle they'll pass through the skull, because the sound wave has to enter at an angle that's sufficient for it to penetrate as opposed to being reflected, and then how that interacts with the tissue. And of course, if you're going to plan a pediatric trial, it's very obvious that the infant skull and the adolescent skull is not the same as an adult skull. There are, of course, the open lines between the bones of the skull called the sutures, as well as the fontanelle, which will actually facilitate sound transfer because of the absence of bone. And then there is the more dense single layer of the adolescent skull, as opposed to the three-layered skull of an adult. And this work is a great deal of which has been done by the folks at the University of Toronto in Dr. Jim Drake's laboratory, have studied the skulls of adolescents and younger children, infants and toddlers, and show the evolution of the shape of the skull as it goes from the adult morphology of having three layers, an inside layer, a middle layer, and an outer layer, from the more simple two-layered arrangement that we see in young children. When we began to create our study, the work done at the University of Toronto helped us pick the arbitrary age of 8, because that's when the morphology of the skull approaches that of an adult based on the density of the skull and the transmission of sound. Another important aspect is how that sound wave is conducted into the middle of the brain and what areas can be reached. And that has implications as we try to design a trial that would use focused ultrasound to treat lesions in the brain that was causing harm. And this diagram here overlaid on top of a sagittal image of the brain is the outline of what can be reached with the current 650 kilohertz device, which is the system that's FDA approved for use in adults for essential tremor. The yellow line is the theoretical treatment volume that could be reached with a newer, yet to be FDA approved device that treats at a lower frequency, but allows for greater passage of the sound and less reflectance as it reaches the skull. Our ability to use this tool in what's called an investigational device exemption was made possible because the device was approved for use to treat essential tremor in adults. And through a tremendous amount of work by a group of centers across North America, they proved that you could target a region of the thalamus called the VIM, or the ventral intermediate nucleus medialis, which was involved in tremor function in adults, and that you could target the VIM effectively, create a small, precise lesion with acceptably low levels of risk, and that this could be done safely. And that ultimately led to this Sentinel paper being published in the New England Journal of Medicine that outlines the trial. And and resulted in FDA approval in 2016. So the question, of course, obviously, is why does a pediatric hospital want a focused ultrasound unit that's used to treat essential tremors in adults? Because children don't develop essential tremor. Excuse me. That's a very uncommon phenomenon in the children I take care of. But we do take care of children with tumors that are in places that are hard to reach. And we take care of lots of children who have epilepsy caused by parts of the brain that are difficult to reach, or that the risk in reaching them may be unacceptable. And some of those lesions are brain tumors. So in 2015, we started mounting this idea of how could we put this technology to use for children? And if we were to do that, what would be the alternatives if the child didn't have access to focused ultrasound? And of course, the alternatives to focused ultrasound treatment would be things like an open operation where we open the skull to reach a lesion, laser interstitial ablation, and I'll talk to you a bit about that because that's an important thing to think about as you balance the risk of what is the standard of treatment for a common lesion and what is the potential for focused ultrasound. And then, of course, other things like radiotherapy, gamma knife, or LINAC, as it may be called. In 2016, we were fortunate to have a fellow work with us who was a trained functional neurosurgeon who did his neurosurgery fellowship in functional neurosurgery at the University of Toronto with Andres Lozano, and then was a faculty member at Mass General Hospital in Boston before he decided that he wanted to be a pediatric neurosurgeon, and spent a year with us. And he was involved in the focused ultrasound treatment of adults with essential tremor before he came to spend a year with us. And Travis Tierney is his name, and he was instrumental in shepherding the protocol that we developed to be able to justify the use of this tool in children. And that study was approved by the Food and Drug Administration in February 28th of 2017. I'm sorry, January 23rd of 2017, and we treated our first patient about a month later. And as of the last time I looked at clinicaltrials.gov, this is still the only open trial for ablation in children on the the FDA's clinicaltrial.gov website. That trial, as designed and which is still open, is open to children between ages 18 and young adults up to the age of 22. They have to have lesions that need treatment and that are considered World Health Organization grade 1. And I'll talk a bit about what that means and why that's important. They need to be symptomatic in a way that doesn't create an advantage of actually taking out the tumor. So a large mass making a child sick that would need to be removed would not be a good target for focused ultrasound ablation. They have to have certain characteristics of the thickness of the skull and a size of the head circumference. And what had been a reason not to be included in the essential tremor trials was having had a history of prior cranial surgery. And fortunately for this trial, we were able to include children who've had prior cranial surgery as candidates for the study. Those people who were considered not candidates were those that had a malignant tumor or were on medications that might make bleeding more likely. There's a list of a couple of those things here at the top. If you have a risk of hydrocephalus with a large tumor that's making you sick, if there's a need for a tissue biopsy and therefore we would need to take a piece of the tumor regardless, then focused ultrasound treatment might not be an advantage. And of course, if there was an alternative that might be acceptable, and the classic example is children who might have an effective medical treatment, that would have to be considered before accepting the risk of enrolling them in a trial like focused ultrasound therapy. There are some implanted devices that cannot go into the intraoperative focused ultrasound unit. Those are things like vagal nerve stimulators or responsive neurostimulators. So as I mentioned, as we deliberated as to how to use the tool, the idea developed of what would be the prototypic or ideal lesion to treat. It would be something that made children sick, that was relatively small, that caused symptoms, and for which the alternative treatments left something to be desired. And I think that prototypic lesion, if anything, would be something called a hypothalamic hamartoma. For those that aren't in medicine, the hypothalamus is this area in the base of the brain that's intimately involved in the homeostasis or maintenance functions of the brain. Things like I'm hungry, I need to eat, I'm I'm satisfied, I need to stop. They regulate my temperature, they regulate your heart rate, they control the pituitary gland, which controls endocrine function. And hamartomas are WHO, World Health Organization, classified grade 1 lesions because they don't grow. They are mixtures of cells that could potentially look normal, except they're disorganized and they're causing harm. They can cause precocious puberty is one of their more common manifestations, early secondary sexual development. And you can see precocious puberty in infants with hypothalamic hamartomas. They cause an odd form of laughing epilepsy called gelastic seizures, and they can be associated with profound behavioral disorders. Eating disorders are part of them, but other sort of disruptive or combative behavioral disorders can be associated with hypothalamic hamartomas. Why would you consider an alternate treatment if an operation could remove the lesion? Well, over the years, many different therapies have been tried for hypothalamic hamartomas, and open surgical resection has been one of them, along with endoscopic resections. And both of those were associated with significant potential risk to the brain in the region of the hypothalamus. And what I have here are a couple of cartoons of the brain next to an anatomic section of the brain. And I don't want to belabor you with the anatomic nuance, but if this is the hypothalamus in this region, and this is a fluid-filled space within the brain called the third ventricle, all of this is very important real estate which surrounds the hypothalamus. And this drawing shows all of the nuclei, the areas of the hypothalamus that are packed, filled with neurons that have essential functions in regulating things like how much urine your kidneys make, what your temperature is, are you hungry, are you satisfied, what's your heart rate. All of those things are controlled here in these tiny little clusters of gray matter of neurons packed into this region. Hypothalamic hamartomas are treated with laser interstitial ablation because reaching this area with an open operation is very difficult. And just a word about what that is so that it makes sense why we've taken on the idea of using focused ultrasound. Laser interstitial ablation means taking a laser fiber in a catheter like this, putting a hole in the skull, passing that catheter down through the brain, and then having laser light emit from the center of an opening or from the very tip. That laser light diffuses into the brain and creates heat. That heat then creates damage in the tissue, and it can be used to heat and destroy tissue at the end of the laser fiber. It was a significant advancement when we started using them in 2009, 2010. But what we quickly realized is that you still have to pass this laser fiber, which is about a millimeter and a half in diameter, through the brain to reach the target tissue. And if you again go back to our hypothalamic hamartoma hanging below the hypothalamus in this MRI scan, and this gray circle represents that hamartoma, well, then this red giant cylinder that looks like a telephone pole going through the hypothalamus would be the laser fiber. And this is roughly scaled to what a millimeter and a half would look like as it traverses the nuclei of the hypothalamus. So plenty of opportunity to improve treatment by not passing this 1.5 millimeter probe through the brain to reach the hamartoma at the base. So this was our theoretical ideal target for focused ultrasound. And as I said, when this trial was created, over the years, we had taken care of many children with gelastic epilepsy, and unfortunately, not all of them had a satisfactory result. And this is an example of a 22-year-old lady who at age 19, had surgery by one of my partners to try to treat her hypothalamic hamartoma. And this is that lesion, and it was treated with an endoscopic resection through the ventricle. And although a portion of the lesion was removed, and you can see that hole left in the hamartoma, she had really no significant improvement in her epilepsy. And as a result of it, ended up developing a significant postoperative weight gain. Oh, I'm sorry, this was a laser ablation, not an endoscopic resection. A laser ablation by my partner when she was 19. And as a consequence of that laser ablation, she developed significant weight gain associated with severe behavioral issues that really sort of reached a crescendo when she was in her early 20s. After a lengthy discussion with her and her family about either another laser ablation or an open operation to treat this, she became the first patient that we treated with focused ultrasound. And the way that's done is with the child in the MR scanner and asleep, and the head positioned within this ultrasound transducer. The system takes a picture, an MRI picture, and then it picks a pixel within that MRI to target with heat. And this little movie here that's about a minute long shows this schematically. So here's the tunnel of the MRI machine, and the head, this is actually the skull of our patient, centered in the middle of these 1,024 transducers. We target this region by doing imaging studies. We turn on the unit to create heat. We create a background temperature map, which is what all the little colored dots are. We create a test dose of heat, which shows where the heat, the tissue is heated. That small test dose is recorded. We then raise the energy a bit. The temperature goes up. And with each incremental rise in temperature, the size of the area that becomes heated is increased. We then move to an adjacent area and start the process all over. So through this very tedious and process that took almost 8 hours to do and involved over 30 focal ablations, we were able to target this lesion and disconnect it functionally from the hypothalamus. Not get rid of it completely, but disconnect it from the hypothalamus in the hope that we can stop it from making the brain sick. And let me see if I can make this guy go away now. So this is that coronal image with this ablation circles going from the inside to the outside. This is that same patient and from a side view as they go from the top to the bottom. And after the procedure, she had no neurological sequelae. She was treated with some steroids to decrease the inflammation. She had an uneventful hospital stay. The protocol mandates that she stayed for 2 days. She had endocrine labs tested. She had no evidence of disruption in the pituitary gland's function. And 2 years later, she remains on medicine. She's had no further seizures. She got married. She had a child. We learned a lot from this procedure. That's helped us do it more efficiently and quicker. And we learned a lot of technical lessons as we went on. So we've treated 4 other hypothalamic hamartomas. They've all been successful. I'll show you those examples here in a moment, but let me show you a failure because we learned a lot from this as well. And this will speak to what we can potentially do in the future and we probably cannot do in the future with this technology. So when this was originally envisioned by my neurology colleagues, because we see lots of children with tuberous sclerosis, which is an inherited disorder that causes epilepsy, and many of those children have these benign tumors that are in the center of the brain called a subependymal giant cell astrocytoma, or SEGA. And they're very common. They respond to medication, but the medication has side effects, and a lot of the children don't like taking them. One of the common side effects are mucosal ulcers and sores. So this is a teenage boy who was a college student in California. He had tuberous sclerosis. He did not have epilepsy, and he contacted us through the referral by his neurosurgeon because he did not want to take his medication any longer because of the mouth sores and the discomfort. He has this lesion, which is relatively small, and I thought was going to be a challenge to treat because of these little bright dots, which are dots of calcium. And as you can imagine, sound waves don't travel very well through calcium deposits unless they enter the calcium deposit at a very precise angle, and they stop a great deal of the sound. And if we're trying to have all the sound waves converge on this spot and there's mineral deposits in it, it's going to create a problem. And what happens is the sound waves bounce off and it creates bubble formation, which is called cavitation. Cavitation could potentially be catastrophic if it got out of hand inside the brain. And the system, the focused ultrasound system, has a listening device that listens for those sound bubbles created by cavitation. And it shuts the power off immediately as soon as it hears the bubbles pop. So although I had reservations about being able to treat this, we agreed to try with the understanding that it may not be practical. So here's the boy's treatment images in the unit. Here's the subependymal giant cell astrocytoma. Here are our targets away from the mineral deposits, which are on this side. So we tried targeting the opposite side of this SEGA. We tried for several hours to be able to create enough heat as far away from the mineral deposits as possible. But each time we did, it was met with cavitation. And essentially, after several hours of this, we quit. And although it was a disappointment for both us and for the young man, we did not create any bleeding in the brain. We didn't cause any harm, thankfully. And eventually he had to go back on his medicine, and we parted friends. But he contributed significantly to our understanding of what we can and cannot treat with focused ultrasound. And these calcifications, whether they're microscopic or macroscopic, large enough to see on a scan, are not suitable to being treated with focused ultrasound therapy. This table here summarizes the 5 patients we've treated so far. 4 of them have hypothalamic hamartomas. They've ranged in age from 22, which is the age mandated by the trial to begin with, down to age 15. And the trial is now approved to go down to age 12. We've not enrolled anybody less than age 15 as of yet. 4 of the patients had hypothalamic hamartomas, and here's the young man with the subependymal giant cell astrocytoma. The size of the lesions are listed here, the types of interventions they've had priorly, and 3 of the 5 patients had prior treatment, an endoscopic resection, a laser ablation, gamma knife radiosurgery, and a laser ablation. And then these 2 patients who had no treatment for their hamartoma or for their SEGA. And there were no complications in any of the 5 patients. And this table just summarizes this. This is from a manuscript that's been submitted for publication, and hopefully it will be published sometime soon in the next few weeks. It shows all of the 5 patients. Here's one of the very first hamartomas, this tiny residual here against the ventricular wall. Here's it after treatment. Here's a larger lesion against the ventricular wall. Here's that same lesion after treatment. Here's another lesion after treatment and before. And then the larger lesion that I showed you previously, and then the pedunculated lesion from before. So these are all of the patients that we've treated so far to date. And they've all had a satisfactory result, with the exception of the boy with the subependymal giant cell anatoma, who had no benefit. All of the other patients have had a complete cessation of their seizures or significant improvement. They've had an improvement in the hypothalamic hyperphagia, and then the boy with the SEGA who had no benefit. And these are all results that have been at the 1 year or greater mark. So this case, which Dean mentioned at the outset, I think is worth showing and then providing some background, because when this young lady's mother was kind enough to describe her daughter's experience and post that experience on the Hypothalamic Hamartoma's website, I got a great deal of interest and enthusiasm from other families whose family members had hypothalamic hyperphagia as a complication of prior surgery. And I think, unfortunately, that's not something that I think can be treated with this. What made this young lady unique is that she had this hamartoma suspended by a little narrow stalk from the hypothalamus. She'd had no prior therapy except for medical treatment for her precocious puberty, which she developed very early in life. She was normal cognitively. She did not have gelastic epilepsy, and she had no other endocrinopathy. And I think what made it reasonable in my mind to treat this is that instead of just saying, well, you got to go on a diet, I and our team at Children's saw all that her mother, who happened to be a nutritionist, had put her child through with extensive calorie counts, as well as experimental medical therapy to try to suppress her daughter's appetite in an effort to control her weight. And in spite of that, her weight continued to escalate over her adolescent years. And we all know how profound an effect that can have on a teenager. So she had a treatment with focused ultrasound directed at the neck of the lesion, which you can see the bullseye target created by the focused ultrasound machine. This treatment took about 5 or 6 hours to do. This is the young lady the day afterwards. In order to do the treatment, you have to shave the head completely so that the sound waves pass through the unobstructed skin and it isn't interfered with by the shafts of the hair. So even the stubble of the hair has to be gone. And she embraced it completely by cutting off her long blonde hair and giving her hair to locks of love. There is a frame that has to be attached to the head in order to fix the head and precisely target the area of interest on the MRI machine. That frame is held in place by 4 pins, and you see the pin mark here on her forehead. The frame has to be as low as possible on the head to expose as much of the top of the head to the ultrasound machine. And then this is the area that was treated 6 months later on MRI scan, and this is Madeline 6 months later. And at this point, she lost 13 kilograms. She's lost now over 16 kilos. She's not gained any of that weight back. COVID and being trapped at home was a bit of a challenge for her, like it was for all of us, but she continues to do very well without any side effects from the treatment, thankfully. So where do we go with this? This trial needs to be completed before the U.S. Food and Drug Administration will give us permission to move on to a broader trial and to expand the indications. We need to enroll 5 more children to be able to complete the trial. And ideally, they would be within the ranges of age 8 to 16, which are the remaining age groups that the FDA will allow us to treat before the study has to be stopped and re-examined by what's called the Data Monitoring and Safety Board. The trial remains open, and we're trying to, as other centers acquire the tool, we're trying to recruit other centers to help join our project in the hope that we can recruit children and complete this study and to be able to move on to what would be called a pivotal trial where we could prove its efficacy and safety before we move on to trying other new modalities. Examples of what other types of lesions might be suitable. This is a germ cell tumor in the region of the pineal gland in a teenage boy who presented with hydrocephalus. If we could make the diagnosis using serum markers, then we could potentially treat this lesion and spare him radiation therapy. This is a astrocytoma, a tumor of the supporting cells of the nervous system in the head of the caudate and in the septum in a child. These also may be suitable candidates. Any lesion that's benign and fits into this blue colored region may be a candidate for treatment with focused ultrasound therapy. Things that are not a candidate for focused ultrasound therapy are things that are heavily calcified, are cystic, or large. And here's a classic example. I've struggled to take care of children with craniopharyngioma over my 25 years in practice here in Miami and 30 years overall. And these lesions are a real challenge. Craniopharyngiomas that have multiple cysts like this, they're embedded deep in the brain, that involve the hypothalamus at the pituitary gland and the optic pathway, and don't respond to radiation treatment, intracystic therapy, and multiple aspirations. They represent a challenge, but unfortunately, because of the calcification that you see on the CT scan and their large size, are too big to treat with focused ultrasound therapy. This past December, we, with the help of the Focused Ultrasound Foundation, hosted a webinar with a group of leading children's hospitals that have ongoing clinical work on the adult side or research protocols involving focused ultrasound therapy to see if there's a way that we could collaborate together to help complete the existing phase 1 study to prove that it's safe, and then expand that to what would be a phase 2 or a study where we would expand its indications and show its safety and efficacy. And we are now in the process of joining this group of people to work on the details of a clinical trial. One of the things that I said is really exciting is this idea of blood-brain barrier disruption and neuromodulation. And this is a list of all of the patients treated using the InsideTech unit. This comes from InsideTech, compliments of one of their lead engineers, Moore Diane. And he has a table here that lists all of the patients that have had treatment for anything other than essential tremor. And what I'll point out to you is that most of those patients have had hypothalamic hamartomas. Those 5 patients, 4 of the 5 patients have been treated by our center at Children's. All have had a response clinically. But what's really interesting is that, aside from the fact that we treated most of them, is that many of those patients had a therapeutic response, but had no lesion created with the treatment, but yet have had a clinical response. And what that tells us is that focused ultrasound energy can be used to treat lesions in the brain without actually killing the tissue as evidenced by destruction on MRI scan. That we can create most likely a functional disruption in the tissue using sound energy. We may not be able to measure that with a significant temperature rise or destruction, but that can affect a positive outcome. And this is a case published by the Japanese earlier in 2020, and it shows a young lady who had epilepsy coming from this region of the temporal lobe called the hippocampus. They were able to target that lesion, but because it's off center and outside of the effective treatment envelope, they could not get the temperature to rise to levels that would create tissue destruction. But in spite of that, this young lady has been seizure-free now for over a year after the treatment. So this ability to modulate neurologic function without actually creating destruction has great potential and will hopefully be something we learn more about as more of us begin to use the tool and expand its indications. I mentioned the exciting opportunity to use tiny bubbles injected into the venous system associated with sound to disrupt the blood-brain barrier. There are active clinical trials now being developed to use this to help get medicines into malignant brain tumors in children and also medications or larger molecules. Even bits of genetic material may be delivered directly into the nervous system. I read a really exciting protocol that's going to use a type of modified RNA, much like our Moderna or Pfizer vaccines that we got for COVID, to be able to change gene expression and improve genetic disease in children with inherited disorders. So much more to come about blood-brain barrier disruption and focused ultrasound as a tool. I think what's really going to be exciting is the ability to expand the treatment envelope from what is now the current 650 device that can barely reach the thalamus with effective treatment and will reach these outer regions, but at very low temperatures. By contrast, the newer system, which uses lower energy and takes a longer time to treat, but yet to be therapeutic, has a much larger therapeutic window than the existing system. So we're hoping at Children's in Miami to acquire this system to be able to expand the area that can be reached with the unit safely into the future. So I just want to finish by acknowledging the many people that were involved in making this trial happen. Dr. Tierney, who I mentioned at the outset, Ian Miller, who was my neurology partner, who's now unfortunately left Miami Children's and I'm now working with Mary Terry Fajardo, Dr. Miller's associate, Nolan Altman, our radiologist, and my partner at the time, who's since passed away, Sanjeev Bhatia, who was instrumental in developing the protocol and treating the first patient with me, and then Shelley Wang, my new associate. I want to acknowledge the Inside Tech team, as well as the Focused Ultrasound Foundation for their financial support. And I thank you for the opportunity and would welcome anybody who'd be interested in coming to Miami, either to watch a treatment or to be considered to be treatment. My contact information is there at the bottom. Feel free to take a screenshot. This lovely picture of Art Deco Miami comes from the New York Times, which says that Miami is now the center of technology, not Silicon Valley. So come down, the weather's just fine. Thank you again for the opportunity.
Wonderful, John. Thank you so much. Really fascinating, very interesting utilization of this technology, and hopefully the research continues on, and eventually this technology is approved for this application, and many people can get benefit from it. There are a couple of questions that came through. So, and maybe we can unpack this a little bit, because I know that anyone who's watching live right now, or certainly planning to tune in later to watch the recording, will have specific questions about craniopharyngioma, and that's largely for two reasons. Stemming out of the fact that this is one of the most common forms of benign hypothalamic tumors that people experience, and that has been a big focus of the Raymond A. Wood Foundation. So a lot of the people that we interact with have either had a craniopharyngioma or have a relative that has had a craniopharyngioma. So could you maybe just unpack that a little bit more around what are the challenges in treating craniopharyngiomas and related tumors with this technology?
Thanks, Dean. So as I mentioned, craniopharyngiomas it commonly present when they form a cyst or cause pituitary dysfunction. for them, in children, they become usually quite large from the cyst, and or the pituitary dysfunction itself makes itself known, excuse me, when they have hormone issues. Obviously, in adults, and there are two peaks to craniopharyngiomas. There's the adolescent peak at the young age, and there's a peak later in life. And they present slightly differently, but most craniopharyngiomas contain mineral deposits, calcium deposits. And at least with respect to ablation, it seems as though those mineral deposits are a barrier to generating enough heat to cause tissue destruction and cell death. Now, what may be intriguing is that we might be able to use those mineral deposits to destroy the tissue, the tumor tissue, by creating sound bubbles and then damage to the craniopharyngioma cells. But that's going to take this incremental work of first understanding how far we can push the technology without causing harm before we consider treating a calcified craniopharyngioma. Many craniopharyngiomas are solid, but also many are cystic. And when you have a large cyst that's mostly fluid filled, what you want to destroy is not the fluid in the middle of the cyst, but the tumor tissue itself, which is around the cyst. So that makes the target difficult to reach. So I think that cystic lesions or solid tumors that are heavily calcified are going to be a real challenge. Now, if there's a small residual tumor that is nestled in the hypothalamus that wasn't able to be removed or made itself known because of a subtle endocrinopathy, that might be a suitable candidate for focused ultrasound therapy. So lesions under 15 to 20 millimeters in size that are mostly solid and not heavily calcified may be candidates for focused ultrasound as it currently exists. But the future may actually take advantage of that calcification to create those cavitation bubbles that might actually help destroy the tumor tissue. So a lot of unknowns, a great deal of potential, but it is an area that can be reached safely with focused ultrasound. Whether we can affect a treatment or not is not known.
Yeah, that's great. Thank you. And there's a comment here that talks more to the challenges with cystic tumors, and it's actually a question about whether if you could successfully aspirate the cyst first with a minimally invasive treatment, for example, burr hole surgery, then would that ease up some of the challenges and make it possible to be able to treat a craniopharyngioma?
Absolutely, yes. And to clarify, we've not treated any craniopharyngiomas. We've only treated 4 hypothalamic hamartomas. And it, under the right circumstances, a primarily what's called an adenomatous craniopharyngioma, which is not heavily calcified, may be a suitable candidate if it can be shrunk down to a reasonable size. And honestly, if it can be shrunk down to a size where it's hovering in the third ventricle or nestled against the third ventricular wall where the hypothalamus exists, that would be an ideal target.
And something that you said that was interesting just now is, so there is potential. I guess the challenge with craniopharyngioma is, as you said, normally by the time that it's been identified, it is quite large and it's having significant impact on endocrine function and behavior that has led to imaging to be done in the first place. And then it's pretty much, gross resection and need to go in and aggressively remove the tumor. But the potential for recurrence provides an opportunity where if there's regular imaging to track the course of recovery after the tumor has been removed, if there is a small recurrence, then getting in quickly, it would be possible then, I presume, to use this technology.
Yeah, absolutely, Dean. So I think if there was a tumor that required surgery because of its size or that's pushing on the optic nerves, and in the end of that operation, there was a small residual left behind, the alternatives at that point would be focused radiation, gamma knife, conventional radiation, proton beam, or electron therapy, photon therapy, or focused ultrasound. And that's exactly the thought process that brought us to treating hypothalamic hamartoma. What are the acceptable options, and when would you intervene? And I think that could conceivably be treated with focused ultrasound, assuming the size isn't too big. I see a question here through the WhatsApp app. You want me to take that one?
Sure.
So this question is asking, in the patients that have had focused ultrasound therapy, has there been swelling in the midline? And of course, that the midbrain lesion that I showed was a theoretical candidate. That's a patient with a germ cell tumor. That's not a patient I've treated. I was showing examples of things in the brain that might be suitable candidates. If the person asking the question may be getting at, if the mass is blocking the circulation of cerebrospinal fluid in the brain, or if we heat the tissue and the tumor and destroy it and it swells, could that potentially block the circulation of fluid in the brain? And the answer is absolutely. That would be a concern. That's a theoretical issue when we were considering treating that child with the subependymal giant cell astrocytoma. So depending on the location of the lesion, the swelling associated with destruction of the tumor could result in a blockage to the circulation of CSF. The patients we have treated so far with hypothalamic hamartoma have had no clinically relevant swelling in the brain that we could identify by doing hormone tests, looking for endocrinopathy, or by examining them carefully neurologically, or by doing an MRI scan 24 hours later. We can see the swelling, but they had no clinical manifestations of that.
Okay. And there's another question here that came through, which is how quickly does it work? So it's interesting. That question makes me think about how you were targeting the neck and basically disconnecting the tumor from the actual brain tissue. But how, what's the process then with the, I guess, the cleanup after that, with the brain actually dealing with this floating piece of tumor that has been disconnected from the tissue?
Yeah. Great question. And if you were to treat the neck of that hamartoma that I showed with Gamma knife, you would wait 6 to 24 months to see the benefit. But with focused ultrasound, that young lady with the hypothalamic hamartoma, the neck of which we targeted, she woke up the next day, and her mom put her breakfast in front of her, and she said, "Mom, I'm not really very hungry." And whereas before so the effect was immediate. And that's exactly what I would expect. I would expect that the disconnection, which damages the neurons and their connection between the hamartoma and the hypothalamus, is immediate. And although it isn't like it's floating free or drifting off someplace else, it isn't anatomically disconnected like you were to cut it, it's functionally disconnected, meaning those connections no longer can transmit nervous signals from the hamartoma to the brain.
Interesting. And just in some of the few minutes we have remaining, I want to ask a question. As a neuroscientist, the thing that interests me about this is not so much aggressively treating the tumors. It certainly is absolutely fascinating, but the potential to use this technology to alter functional activity in the brain. You were talking a lot about behavior and dysregulated behavior because of the tumors impacting neuronal function. But there has been some research with low intensity focused ultrasound pulsation. And certainly for this patient population, where there have been large portions of important brain structures that have been ablated after aggressive surgery, particularly for craniopharyngioma. What are your thoughts about the utilization of low intensity focused ultrasound pulsation to be able to improve neuronal function where there's been that damage?
Yeah, great question. And I think that is going to be the new frontier. I think this initial iteration of the technology where you're using focused energy to heat and destroy tissue, I think is going to have very limited application ultimately. I think the great promise is going to be able to alter function either transiently or permanently using focused ultrasound energy. Some of that may be heat, some of it may be mechanical disruption, that disruption will hopefully alter cellular function in a way that we can use to the patient's benefit, whether it's creating modulation of function. A great example is there's an ongoing study in Toronto now treating the basal forebrain of patients with Alzheimer's disease with repeated low energy focused ultrasound treatments, not to destroy the tissue, but to modulate function in that region. in the hope that they can moderate the manifestations of the Alzheimer's. And I think that's really going to be the future. As you know, Dean, there's ways that you can temporarily interrupt networks within the brain using focused ultrasound energy, lower energy, but you can target it precisely. So as I mentioned at the outset, we take care of lots of children with epilepsy. Epilepsy is a network disorder. The network of neurons in the brain seems to be misfiring, and it may be an anatomic abnormality that we can see on an MRI scan, but it's often not. So we can physiologically image those networks, but we can't really target them without poking the brain. But potentially with focused ultrasound, you could then begin to target clusters of interconnections, networks of neurons, and turn them off briefly to assess the effect on the child's epilepsy. That has tremendous potential in the future. And I think the future is going to be using low energy to sort of explore function on a transient basis, and then, if need be, to then go on to make that permanent if it's beneficial.
Yeah. Fascinating. We've got a couple more minutes, so ask another selfish question that I have an interest in is the potential utilization of this technology, the high intensity ultrasound for pituitary adenomas.
Right. So the pituitary gland, as you know, lives in a little cup of bone called the sella turcica. That creates constraints within the sella. So if you have a small intracellular lesion, I suspect that we're going to have a lot of trouble getting enough energy into the sella because of the shadowing created by the cup that the pituitary gland lives in. So for those who aren't familiar with the anatomy of it, the pituitary gland lives in a little cup like this. It hangs from a stalk, and under normal circumstances, the gland lives in that cup, but the cup itself is all bone and it's covered by a membrane. The membrane itself gives us very limited access to it. So we have not tried to treat that, but efforts to model that treatment have suggested that it's not going to be possible to generate enough energy to ablate a lesion in the gland. Whether we could deliver lower doses of energy that might be able to moderate function, because as you know, the pituitary gland is a neurohumoral organ. It's a combination of neurons that produce hormones. It may be possible to create a modulation, but probably not destruction.
Right. Well, thank you so much. This has been incredibly informative. I'm sure we're going to have a number of follow-up questions come through as people get a chance to watch the recording. So thank you so much, Dr. Ragheb, for taking the time to join us and to share this fascinating research. And we hope to get some updates as it progresses.
I'm looking forward to sharing good news in the future. Thank you, Dean, and thank you, Amy, for the opportunity, and have a great evening.
Thanks so much. Take care.
Bye-bye. You too.